So today we begin with a talk by Dr. Indira Vijayakrishnan on the topic, the hyperandrogenic PCOS, a bigger threat. May I please invite all the chairpersons onto the stage. Dr. Sheila Mani, Dr. Valsamma Chako, and Dr. Preeta. Dr. Indira Vijayakrishnan is a consultant gynecologist, laparoscopic surgeon, and infertility consultant in Amar Maternity and Fertility Center. She also holds a diploma in gynec endoscopy and advanced diploma in reproductive medicine. Welcome, ma'am. Over to you.
Good morning to one and all. I'm Dr. Indira Vijayakrishnan. I'll be speaking upon the hyperandrogenic PCOS and how it is a bigger threat. So first of all, I would like to give my hearty congratulations to Team KJK for achieving this amazing feat for 25 years. So if you see this patient, a 28-year-old lean PCOS with irregular cycles, you would probably advise her lifestyle modifications, and you would give her OCPs if she's not planning to conceive, or ovulation induction if she's trying to conceive. If so, which OCP would you give? Would you decide by the brand, the price, the dose of the estrogen, or the type of progesterone? And what other investigations do we usually do? Prolactin, thyroid, HbA1c? What if this was the patient, obese, acanthosis nigricans, hirsutism, acne? Then we would go on and on about diet and exercise and weight loss. We would do the same investigations, and we would probably manage the same way. OCPs if she's trying to regularize her cycles, and induction if she's trying to conceive. But would you want to address her hyperandrogenism first? So what about this investigation called testosterone? Should be a routine investigation in all PCOS or only in those with hirsutism? So what are the tests that we should do? Is it serum testosterone or androstenedione or DHEAS? And does it change the way we would manage our patient, or does it change the patient's outcome? So this is what I'll be addressing in this talk. And we have the International Evidence-Based Guideline for PCOS Management, which is a collaboration from the ASRM, ESHRE, European Society of Endocrinology, the Endocrine Society, and Monash University. So they all seem to agree upon certain guidelines. We all know about the Rotterdam criteria, which has oligoanovulation and polycystic ovaries, along with hyperandrogenism. That is, biochemically, a total testosterone more than 70, or clinically, hirsutism or acanthosis. This was revised later, but there's actually not much difference in this new modified Rotterdam criteria. And polycystic morphology in adults has been changed to define as more than 20 follicles in at least one ovary, or more than 10 follicles in one section of the ovary, or an ovarian volume of more than 10 ml. But this classification should not be used in adolescents. So surprisingly, if you notice, in patients with irregular menstrual cycles and hyperandrogenism, you don't even need an ultrasound. An ovarian ultrasound is not necessary for PCOS. You just need irregular cycles and hyperandrogenism to tell a patient that she has PCOS. So these are the three common criteria that we follow. One is by the NIH, by the Rotterdam, and the Androgen Access Society. So you can see that along with and/or oligoanovulation and polycystic ovaries, one criteria is constant in all the other three classifications, and that is hyperandrogenism. So hyperandrogenism is just not about a little hair. It's about other than hirsutism, acne, alopecia, acanthosis, insulin-resistant PCOS, OHSs, preeclampsia, pregnancy loss, hypertension, diabetes, and even cardiovascular disease actually. So we know that PCOS has four phenotypes. Phenotype A, B, and C are hyperandrogenic. A has all three characteristics like PCOS, polycystic ovaries, hyperandrogenism, and irregular ovulation. B has hyperandrogenism with irregular ovulation. C has hyperandrogenism with polycystic ovaries. And D just has polycystic ovaries and irregular ovulation. So these categories are really different because you can see that the hyperandrogenic categories are more prone to have insulin resistance, glucose intolerance, or diabetes. And if you see this pie chart, it's only that green portion which is not hyperandrogenic. So it is easy to say that more than 75% of PCOS are actually having hyperandrogenism. And that just doesn't give them infertility or irregular cycles, but lots of cardiometabolic abnormalities like dyslipidemia, hypertension, diabetes, atherosclerosis, coronary vascular disease. Hyperandrogenic PCOS have almost a 5 to 10-fold increased risk of developing PCOS. And PCOS is the most common endocrinopathy affecting reproductive age women. And when 75% of them are hyperandrogenic, shouldn't we be addressing that? So studies say that almost 70 to 80% of PCOS have infertility, and the prevalence of infertility per se was 15-fold higher in those with PCOS. And we already know that they have a worse obstetric outcome in terms of congenital anomalies, gestational diabetes, hypertension, preeclampsia, miscarriages, cesarean deliveries, FGR, LGA, and all this is because of the hyperandrogenism and insulin resistance. If the person is obese, there is added insulin resistance, and when they enter pregnancy, this whole thing is exacerbated. And there's also an incidence of insulin resistance of up to 70% in PCOS. They also have an increased risk of early pregnancy loss to the tune of almost 50%. And though the exact reason why hyperandrogenic PCOS have more hypertension is not really known, it's said to be because of the stimulation of the renin-angiotensin system. So the risk of preterm births and preeclampsia is also associated with hyperandrogenism. There's an association with cervical incompetence. And if you can think of the patients that you did not put in a stitch for and who had a sudden second trimester loss, you might think back and remember that they were polycystic and hirsute. So hyperandrogenic women with PCOS have a twofold increased risk of preterm delivery and preeclampsia. Hyperandrogenism with chronic anovulation, it increases the androgens and the inflammatory cytokines in the follicular fluid, and that has a negative impact on the oocyte and the embryo, and it even affects the rate at which the embryo grows, again because of the hyperandrogenic microenvironment. So just some food for thought. So there has been a lot of voices in the recent years questioning the Rotterdam criteria, and there is a society called the EGOI PCOS, that is the expert group on inositols and PCOS scientific study, and they have been proposing to differentiate this hyperandrogenic groups, that is ABC, into what would be later called type 1 to 3 endocrine metabolic syndrome, and only the non-hyperandrogenic patients, that is what was normally phenotype D, as true PCOS, because only they had actual PCOS, polycystic ovaries and anovulation. So this EGI PCOS has proposed a formal separation of the typically insulin resistant and hyperandrogenic PCOS patients. And this is important because we all know that insulin resistance plays such a predominant role in the etiopathogenesis of this hyperandrogenic phenotype, and it has been completely ignored in all the previous classifications. So this is a recent study published in 2025. You can see it compares hyperandrogenic and normoandrogenic PCOS, and you can see that the hyperandrogenic phenotype A, almost 74% are obese, whereas in phenotype D, it's only around 47%. And if you see the primary outcome, the group D, that is phenotype D, and the controls have almost similar outcomes. They do differ in the number of oocytes, but the outcomes are similar. Whereas the group A, which is the hyperandrogenic, they have a much lesser biochemical pregnancy, ongoing clinical pregnancy, and a higher miscarriage rate too. So a high BMI associated with insulin resistance and hyperandrogenism consistently changes the pregnancy outcomes. And there has been no difference between phenotype D and controls. So there are other studies showing the oocytes retrieved from non-hirsute donors who had a PCO morphology. Even in them, there's no negative outcome on pregnancy, miscarriage, or live birth rates. So what do the guidelines say? Biochemical hyperandrogenism. So free testosterone must be estimated. So if testosterone or free testosterone is not available, we can go for DHS, but is less sensitive. The free androgen index is something calculated by testosterone by sex hormone binding globulin, and testosterone samples, please note, should be drawn in the morning, preferably on day 2 or 3 of a period. For the detection of hyperandrogenism, the assessment of biochemical hyperandrogenism is of greatest value in patients with no clinical signs. So it is not in a hirsute that you should see the testosterone. That is relevant to see how your treatment is working out. But it is in a person with no hyperandrogenic signs that you must actually test the testosterone, because you are going to find out which class of patients is going to give you most trouble. So the OCP obviously helps to increase the SHBG, and so if a patient is on the OCP, you should give her a 3 months gap before assessing testosterone. Now coming to clinical hyperandrogenism, hirsutism is what defines clinical hyperandrogenism, and not acne or hair loss. They are less specific. And there is a potential severe psychosocial impact of clinical hyperandrogenism. And take note that unwanted excess female pattern hair growth or hair loss is important regardless of how severe that looks. And we have the modified Ferriman-Galway score, and the most obvious or most prominent areas are upper lip, chin, and upper thigh. Considering these 9 areas, we go scoring them from 1 to 4. We add up the score, and if it's more than 8, we have hirsutism. So always remember that for hirsutism, visual scores are preferred. And always remember that a self-assessment, you ask the woman, do you think you have excess facial hair? That question is more likely to give you a correct answer, because remember that women treat their hyperandrogenism cosmetically. If you see a woman with apparently no facial hair, don't assume that she does not have it. So the combined OCP could be recommended in all reproductive age adults for management of hirsutism. But remember that there is no clinical advantage of using higher dose of EE like 30 or more than 30. So what is commonly marketed as the treatment for PCOS, the 35 microgram ethinyl estradiol with cyproterone acetate, it's actually second-line therapy. Progestin-only contraceptives also can be used for endometrial protection, and they can be used in hirsutism, but we should know which progestin to use. And in combination with contraceptin, and anti-androgens can also be used. Metformin has only a small role in hyperandrogenemia. COCPs should be used over metformin for management of hirsutism, and it's only in people in whom COCP is contraindicated or poorly tolerated that you would consider metformin solely for correction of hyperandrogenemia. We can use anti-androgens, but use it under the cover of contraception, because it can cause undervirilization of male fetuses. Anti-androgens like spironolactone, aldactone of around 50 mg per day, cyproterone, finasteride, flutamide, leuprolide, glucocorticoids, we have a lot of them. And these should be considered if 6 months of COCP does not bring down your testosterone levels. So we have all these pills, OC pills containing anti-androgens. So which progesterone do we prefer? Of the 4 generation of progesterones, please note that the second and third, which are commonly seen in the OC pills like levonorgestrel and desogestrel, are actually hyperandrogenic. They do increase your androgens. And it's only cyproterone, dynogest, and drospirenone which are anti-androgenic. Drospirenone, because it's a spironolactone derivative, you can see that it is most close in action to endogenous progesterone. It has no glucocorticoid activity. It has anti-androgenic activity and anti-mineralocorticoid activity too. Dynogest and cyproterone, yes, they do have similar properties, but not all the good effects of drospirenone. So drospirenone decreases body weight, decreases blood pressure, decreases LDL, increases HDL, and improves PMS. So we have combinations of 3 with 30 of EE for 21 days, or with 3 of 20 of EE for 24 days. Both are effective. And drospirenone blocks androgen receptors in the skin, so it helps in the hair growth, but it does not prevent the androgen binding with sex hormone binding globulin. It decreases LH. It increases aldosterone release. It has an anti-mineralocorticoid mechanism. It increases sodium and water excretion, decreases bloating, weight loss, hypertension. So it's called the pill with metabolic neutrality, and it is preferred in people with worse metabolic profile or cardiovascular risk. It does not deteriorate insulin sensitivity, does not alter liver enzymes, and increases HDL. It's in fact even being considered as menopausal HRT for women with cardiovascular risk. Dynogest, also OC pills containing dynogest, also have no glucocorticoid and no anti-mineralocorticoid activity. And they can also be used in the 2 and 30 combination for 21 days. Coming to inositol or metformin, our international consensus and ESHRE, they all say that inositol could be considered, and that metformin should be considered over inositol. And they do not really speak of any dose, and we have so many doses in our market: 500, 1 gram, 2 gram, 4 gram. But this group that I was speaking about earlier, the EGOI, they specifically acknowledge the benefit of both myoinositol and decanoinositol. And please note, they are a scientific group researching on inositols and PCOS alone, so their work is pretty impressive. And inositol supplementation in a 40:1 ratio can help. And other treatments like light and laser therapy for permanent reduction of hair growth can also be considered. Bariatric surgery only as a last resort. So to conclude, what can we do? Idealize the environment before starting. Lose weight, that is definitely the golden mantra. A diet which can be continued through ovarian stimulation and through pregnancy, not something which is really drastic, and as soon as the patient is pregnant, she stops. An exercise regimen which can be dampened down. Reduce the testosterone level before starting treatment. Metformin and myoinositol can be used. 2 gram myoinositol has been stored in a lot of studies to reduce the testosterone levels. Prefer low dose OC pills, that is 20 EE, with drospirenone or dynogest. If not working, move on to 30, and only if not working, move on to cyproterone. Establish normalcy before starting. Evidence shows that PCOS with pre-treatment with drospirenone EE combinations had significantly decreased rates of preterm delivery, pregnancy loss, low birth weight, fetal malformations. And it is essential for overweight obese women to adopt lifestyle measures, and a very low calorie ketogenic diet has shown promising results. During pregnancy, keep in mind the likelihood of GDM, preterm labor, preeclampsia. And in PCOS ART pregnancies, there's a higher incidence of pregnancy loss to cervical incompetence, and that's worse if it's a multiple pregnancy. So watch the cervix. So check for hyperandrogenism, check for insulin resistance, check the lipid profile in every PCOS and correct it. PCOS is an endocrine and metabolic syndrome. It is not something found in the ovaries. The ovaries in hyperandrogenic PCOS are just mere puppets. So maybe it's time to rethink the nomenclature. There is nothing cystic and nothing ovarian about it. So treat the cause and not the effect, and aim to normalize the patient's endocrine environment before starting any fertility treatment. Thank you.
Thank you, Dr. Indira, for the impactful start to our final day by shedding light to an issue that continues to affect countless women across ages.